wanted to welcome everybody to our first episode of what I call the Complex Case Discussion Series. We're going to be doing a monthly event joined by some colleagues to really discuss cases and take this to kind of a conversation level of real life situations. So today I am joined by three, including myself, three good friends, colleagues. I've known these guys for a long time. We have treated many patients together. First, I'd like to welcome Dr. Flavio Rasetto, prosthodontist in Chevy Chase. Thank you for being here. Our second guest and third guest, partners, both endodontists in Chevy Chase, Dr. Pirooz Zia and Reza Farshey, two of the finest endodontists that I've ever worked with. We have had the pleasure of collaborating on many patients over the years, and it's just really wonderful to have you guys on board. Thank you for being here.
You're welcome.
Now.
Yep. Yeah.
Yes?
Yes.
Yep.
Okay. Fantastic. All right. And here's the team. So today's case, I'm going to present this case. Now, just to be clear, this is the case that I treated, but Dr. Rasetto, Dr. Farshey, and Dr. Zia were not involved in the treatment of this patient. But I think there's a lot of interesting points about this case that I think will teach us many different things to think about. Let's get into it. So this is a 26-year-old patient who was seen for evaluation of trauma one day after she had a fall. It was a bike accident. So she had avulsion of tooth number 9 that had actually fallen on the ground. The tooth was picked up with hand. It was wrapped in a tissue paper, according to a report, and then she went to the emergency room. At that point, the tooth was, I think, irrigated and was re-implanted. By the time it was re-implanted back into the socket, it was approximately 3 to 4 hours later. And what patients really showed here is initially in the clinical exam, teeth number 8, 9, and 10 were involved. Tooth number 8, fracture, Ellis class 2. There was a pulp exposure with no mobility or displacement. Tooth number 9, fractured Ellis class 1. It had 3 out of 3 mobility. That was a tooth that was avulsed, of course, and it was replaced in a delayed fashion. And tooth number 10 had a Ellis fracture type 1, no mobility and no displacement. So her periapical x-rays basically showed enlarged, widened PDL space on tooth number 9. That was the avulsed tooth. Teeth number 8 and 10 appeared to be intact, aside from the incisal fractures. And the cone beam CT scan, which is the imaging that was done at the time of her presentation, kind of showed the intact alveolus on all 3 teeth, very thin bone on number 9, and of course the widened PDL space. Here is the CBCT on tooth number 9, showing the malpositioned tooth within the socket. It's not seated all the way in. It was simply just placed in the socket. It was not splinted. It was not held with anything, but just really laid in there. But we can appreciate that there is bone on the buccal aspect, even though it's thin. So what are the treatment plan considerations? So I think this is a good time to really talk about this case, and I think from a multidisciplinary standpoint. And just to summarize the clinical exams, aside from everything that I described, tooth number 9 was also in hyperocclusion. When the patient was biting down, it showed that it was clearly in hyperocclusion. So I'm going to open this up as to a surgical restorative endodontic assessment and planning. I'll start first, and then I'm going to turn to Dr. Farshey and Dr. Zia about the endodontics and then the restorative implications. From a surgical standpoint, of course, what are the considerations? The considerations are how we can achieve a stability of any teeth that we can save. If there are teeth that are mobile that we can salvage, whether to splint them, whether to extract them if they're non-restorable or if they have poor prognosis. Certainly repair of any lacerations, management of any gingival lacerations, and management of any dental-alveolar type of fractures. Obviously, in this case, we don't have necessarily a dental-alveolar fracture, so really the primary surgical intervention for the trauma is really localized management of minor gingival laceration or contusion, and management of the tooth number 9, which from a surgical standpoint and long-term standpoint, I thought it had a poor prognosis. And that's one of the key factors in the decision, the treatment going on. So let me turn and I want to kind of ask, when I'm given a situation like this, patient walks into my office, right away I have to think about 2 other things. What are the endodontic implications of these 3 teeth right away, as well as the restorative? So Pirooz, Reza, tell me what you think about a patient like this at early phases of treatment.
Thank you for having included us. It's always a bit intimidating to have Reza on the same panel because he knows more than many. We live in a bit of a bubble in many ways here in Washington, D.C., where patients have access to a lot of different kinds of treatment. Let me just ask, and in collaboration with Reza, let me just ask, what would we have done? What would a typical dentist have done had this occurred where there wasn't really a lot of alternatives for care? What could they have done to have increased the prognosis, which in this case, I agree with you, is guarded? What are the steps you would have taken if a patient had come in looking like this? And I'm going to throw out a few of those steps, and then I'm going to let Reza chime in. Obviously, this tooth has not been placed in the socket all the way. So at this stage, it would have been nice to numb the patient up and to make sure that this tooth is placed all the way back where it belongs, number 1. Number 2, you want to think about stabilizing the tooth, and what the AAE recommends is a splint sort of with a 0.4 wire for about 1 or 2 weeks. But it's very important that early on you try and minimize the possibility of this tooth becoming necrotic, which is very likely to do, and B, minimizing the chances of ankylosis by dressing the tooth with some form of corticosteroid. Then it's important to place the patient on antibiotics as well. And the splint is going to stay on for a couple of weeks. Reza, what are your thoughts with regard to some of those steps?
Thank you. What you first said is really it sits with me, and it's such a crucial point that what are other folks going to do in areas where there's no access to specialty care? How can you deliver optimal care for these patients? Trauma cases go up statistically seasonally, and kids love to be outdoors, and accidents happen. And the best I can say is it's up to the neighborhood or general dentist in that area to enhance their education, whether it's online or resources. AAE.org has a fantastic resource. There's a website, IADT.org, International Association of Dental Traumatology. All of their resources and guidelines are free of charge. There's an app called Tooth SOS. steps to do when you're, encountering different kinds of trauma and how to manage them. And then as for patients, there's these Save a Tooth jars that you can buy, again, from the AAE. So you can kind of put the tooth in the jar where it's a safe medium, it'll preserve it. So these are all little things you can do in areas where you don't have access to specialized care in order to intervene and manage your patients in the best way possible. So I encourage you guys that don't have access to specialists in your area to look at those resources for optimum information. As far as this case goes, I think anytime you have trauma, it's paramount to have an endodontist and a surgeon sort of be the initial triagers, if you will, management in a complementary fashion, sharing information in terms of prognosis and managing it, in the best possible way. That's really the only other two things I can add to what you had said, Pirooz, which is 100% correct in terms of management of these cases.
What did we leave out, guys? Flavio, Hamid.
So thank you. I think one of the critical things that I wanted to point out about the endo, and this is sort of my perspective as a surgeon, right away when I'm seeing a patient like this, I'm already preparing them that there's going to have to be an endodontic evaluation assessment in a very timely fashion after this treatment. And just to clarify is that how soon after the trauma should they be receiving their very first endodontic evaluation and assessment? Within days, 1 week? Does it depend on certain factors?
As soon as is practical.
Yeah, it's not. There's never too soon. I think that's.
So literally within even a day or two to get that initial assessment and get a baseline assessment. Great.
Yeah. So if she had walked into
Flavio,
So if she would have walked into your practice and you had no choice but to want to make the best of what is a very bad situation. By the way, don't get me wrong, I agree with what you did, and the case turned out beautifully. So I'm not criticizing that at all. I'm just saying if you had no other options, you would have numbed her up, you would have replaced the tooth fully back into the socket, you would have placed a flexible splint, and you would have sent her straight away for us to make an access, put letter mix or corticosteroid into the canal to try and minimize the possibility of ankylosis down the road, which is a problem with avulsed teeth. And then we would have brought them back in a couple of weeks to do root canal therapy with interim calcium hydroxide treatment. You would have also placed the patient on some antibiotics, doxycycline or amoxicillin, depending on the rate. That's about it.
So Flavio, needless to say, these patients really have an emotional experience. I can't tell you that how many times patients who have this type of trauma to the anterior teeth, they're pretty shaken up. Aside from the accident itself, it's right in the aesthetic zone, and it is a tough experience to go through. So in terms of getting these patients at least some sense of function and aesthetic treatment to get them back online, what are the things that you think about in a situation like this?
Well, number one is to reassure the patient that there are possibilities to help the patient right away. So, as a matter of fact, a couple of months ago, I have been involved in a particular patient that happened to me, that the patient left the office and just fell on the sidewalk and just had a lateral, basically, fracture of the cortical plate, and the tooth was displaced. Adding to what Dr. Pirooz has mentioned is location of the tooth properly into the socket. Now, from the point of view of the occlusion, obviously these type of situations are crucial for us to make sure that we clear the occlusal contact, so we minimize the time for any type of trauma that we can exacerbate what the patient is going through the process of healing. Then the other thing is these type of fractures that involve, like in tooth number 8 and number 10, obviously there has been a concussion on the 2 teeth, and we want to perform a procedure to cover the exposed dentin and provide some sort of a shape to the tooth structure, so we can incorporate, in case that we are planning to add a soft splint, that we have the framework of the areas that we're going to be utilizing as a splint ready for us to perform this procedure right away. So the other thing that a tetanus booster, since this patient had the tooth onto the floor, that could have been most probably addressed during the time that this patient was seen, obviously, at the hospital. But it's important to make sure that the patients are aware of this. Then I think that, as we were discussing before this presentation, planning how to provisionalize this patient. If we have able to maintain the tooth in position, obviously with the soft splint, where we use the 0.4 millimeter threaded wire with just edge, a spot edge of the composite on the facial aspect, and we can have across at least these 3 teeth or 4 teeth that are involved in this soft splint, and making sure that we have a low profile, splint, means that the bulk of this has to be in such a way that we are not inducing too much, trauma into the upper lip, for instance. And then making sure that the occlusal clearance is there, so we minimize direct contact with the tooth that has been avulsed in this case.
Got it. Very good. Now, one of the questions that comes up in this case is, the patient is sitting there and the tooth is already in the socket. And so what's wrong with keeping that tooth and splinting it? Because the other option is to have it taken out. Remind you, the tooth was out for 4 hours, maybe not handled properly in this case. What are we going to expect should we decide to keep this tooth in place? What's going to happen? I'll tell you what I'm concerned about, and I don't know if you guys agree, is whether or not the surface of the tooth is going to take, whether or not there's going to be an infection, whether or not it's going to be stable. But is this a valid treatment? Do you think that there's any place, any hope for a tooth to be maintained and splinted in place and long-term success? Pirooz Zia?
We've had cases. Actually, I was talking with a colleague today who was mentioning we've had cases like this that 10 years later are doing very well. Now, a point that you make, which I think is very, very valid, is listen. Okay, we live in Washington. We have options. What are the downsides of keeping this tooth? What deleterious effects could there be for any future options to be performed, right? And certainly there is a chance that a case like this we can have replacement resorption, which is ankylosis, and that's going to make it potentially difficult for the tooth down the road to be replaced with an implant. You can have an infection and lose that valuable thin layer of bone that you have on the facial aspect of the tooth, which again is going to make the future implant a difficult option. So those are the downsides of keeping this tooth when you have other optionalities, which is why I'm in agreement with what you did.
Okay, so let's
Reza,
go ahead and take a look. No, thank you. Reza, please.
I think that even if a tooth has a 4-hour extraoral time, not in a suitable medium, the odds are not that good. It's a very guarded prognosis, but I think the treatment would still be to reimplant it. And even if we were to reimplant it, and Pirooz is absolutely right, the worst consequence that we want to try to avoid is ankylosis, but we have a series of recalls set in place to catch that at a very early stage and then recommend extraction. So I think that the notion of, if we were to replant it back in and do the endo and the patient left the country to go, somewhere remote for 2 years. No, that's not really part of the treatment. Really is really having a very regimented follow-up schedule to ensure that if resorption is happening, ankylosis is happening, then we're going to intervene in a timely manner so we can still extract the tooth and go for an implant.
Yeah, so this was all discussed with the patient, of course, as options, with prognosis of each option was disclosed. So in this case, patient was, I guess, agreed and consented to the removal of the tooth for a more predictable replacement option. And that's what was done. So let's go through some treatment options. This is more of a emergency surgical management. In fact, this case was done on a Friday afternoon, you know, so not much of a time in advance or time to wait. So the options that we typically have, and this is a chart that I look at every time I want to look at what options do I have for any kind of extraction situation. The first option is sort of extraction and graft the site, come back 4 to 6 months later to place the implant, another 3 to 4 months later do provisional, and then final restoration. The second option is extraction, immediate implant, and a site graft, and then 4 months, 6 months later, come back to do the restoration phase. And the third option is the extraction, immediate implant, site graft, and immediate provisionalization, and then wait about 4 to 6 months later to do the final restoration. These are always the options that we have, and we have to pick and choose. So in this case, it's elected to do the extraction immediate implant with a site graft, and there's a specific reason why we can do this in this case, and I'll describe that in just a minute. The second decision is what type of extractions. Now, in this case, the only option we have is conventional extraction, but let's say that the tooth was not avulsed, not mobile, but fractured vertically deep, non-restorable. We do have the option of doing a partial extraction therapy using the socket shield technique. We've talked about this in the DC forum in our previous meetings as a very effective way to maintain that bone in the buccal corridor. So certainly that's an option that I entertain when possible. And the third sort of thing that we have to think about is transitional strategy, and this is where Flavio will come in to let us know. There are many different options, everything from flippers to implant-supported provisionals, customized healing abutments, snap-on, but this is kind of an emergency situation on a Friday afternoon. There's no impressions, there's no preparation for this. So in this case, we elected to do a bonded provisional using her own tooth. I'm going to open up this idea in just a minute, and I want to kind of hear about some of the other options that we might have as a transition. But essentially, the treatment sequence that we have in a case like this is emergency management surgically. In this case, just extraction, immediate implant, and gap graft. Restorative-wise, the transitional restoration using the bonded provisional. Endodontics, non-surgical management of tooth number 8. Then we come back for surgery for exposure and connective tissue, and then the restorative phase. What do you think? What do you guys think about this? Thoughts? So I'll go with, in terms of endodontic evaluation and endodontic treatment. Any comments there about how you would manage the endo treatment?
Rez, do you want to take this one?
I think, you know, taking the, from an endodontic perspective, if we're looking to endo treat number 9, there would have to be a good diagnosis for it, whether the patient has increasing sensitivity, and we determine through a diagnostic workup that is irreversible pulpitis or pulpal necrosis. But, you know, endodontic treatment wouldn't be indicated just because it's had a concussion trauma. So there has to be something else to go with it. I think you mentioned, I was reading the notes that there was a pinpoint pulp exposure. So and then the patient had increased sensitivity to hot and cold. So if assuming that those are validated.
Tooth number 8.
Yeah. assuming that those are validated at the diagnostic workup, then we want to do endo on number 8. I would probably say the only thing of value here to add would be to use one of the sealers that does not stain, perhaps. I'm thinking sort of from an aesthetic end result, not to have that graying in the roots. So anything with the eugenol based, some of the bioceramics can also stain. So I think my thing would be to resort to a resin-based sealer. But that's really, I think, really getting too into it. But other than that, it's just pretty straightforward. Nothing else to add to that.
I echo what Reza has said. First, let's make sure the endo is necessary. Do we, in fact, have an irreversible pulpitis? Signs of that would be thermal sensitivity, biting sensitivity. And if that is the case, an endo is initiated. Just I don't know who whether the folks watching or endodontists or general dentists. But obviously, the triad of successful endo is complete cleaning, which has to go along with some shaping of the canal. There's some new technologies these days that can ultra clean the canal. And when it comes to obturation, I agree totally with Reza. You got to make sure you obturate the case fully to get a nice cork. And at the same time, you want to make sure you use materials that won't stain the tooth. Kerr sealer would, some of the more recent sealers won't.
Great. So Flavio, this tooth number 9 is out. Next thing you know, I'm calling you saying I have a patient with trauma that we just managed. And there you come in. You guys are thrown in after the fact. This is after the emergency management.
Yeah.
And
so,
then you get a emergency appointment to give this person something to go by. Tell me what you're thinking about.
Well, I think that the decision that you made with your colleague, with our colleague, of having the same tooth to be utilized as a fixed provisional, it was the right call. The fact that you have the tooth extracted, you can measure the clinical crown that you had to restore, so you can recontour the tooth properly. And then it's important, if you have a restoration already number 8 and number 10 done, obviously in this case, I would be performing that procedure if possible. And then the tooth can be bonded by creating roughening on the surface, understanding that the occlusion is so crucial. Because sometimes if you are positioning the tooth without paying attention where is the opposing tooth, then you end up having a lot of adjustment to do after the fact. The other thing is sometimes you have to consider that tooth mobility would occur, and when you have this tooth bonded to both ends of the adjacent teeth, sometimes one end could break on you. And that's one of the things that happens when we are bonding to anterior teeth, especially if we are planning to keep it for an extended period of time. So sometimes what I use, if the occlusal clearance allows me, is to have an extension on the palatal surface, either ribbon or any of those material that we can reinforce the bonding capability of the tooth against the adjacent teeth that we're trying to maintain. There is another technique that you can use, is a resin bonded fixed partial denture. Using the thing is that since this teeth has been traumatized with some degree of concussion, so you have to be careful how much load you're going to be putting into it. So I think that the appropriate decision was the one that you guys has made. We do have the possibility to obviously to make impressions and fabricate an Essex appliance, which is quite a very common aesthetic option for patients that are suffering this type of problems. Either a transitional partial denture or a Nesbitt type of design, which has been listed as an option. It is obviously a fabrication that will take in the laboratory, unless you have your own capability to do this, chair side in your lab. It will take some time until the patient can have something in their mouth. So from the point of view of the chance that you were considering a dental implant to be placed, there are certain basic principles that we follow. If the site has allowed you to have primary stability and the implant is stable, reaching certain amount of torque, you could consider a fixed provisional implant support restoration. There are certain risks obviously involved for the type of trauma that this patient has had. So we have to be cautious to make that decision as well. And there is obviously more and more a tendency to have some of these snap-on or snap-it type of prostheses that has to be made in the laboratory. It doesn't happen, at least you have 2 or 3 weeks of lab time for this to be generated, and you have to have the impressions done, obviously.
Okay. Yeah, I think in terms of a transitional, if this tooth, let's say, was fractured, even the crown, and we could not use it, let's say, probably, at least from a surgical tissue management, and Essex appliance seems to be the most easiest, least costly, and most tissue-friendly transitional prosthesis. And I always ask for, Essex appliance. Is that something that's aligned with how you like it?
Absolutely. I think that is very versatile. It's very simple to make. You could have an investment to have the equipment in your office and train your assistant to have this done. Obviously, there is definitely no question that would be a #1 option. Sometimes happens that depending upon the occlusal relationship that you have, depending upon the type of patient that you're dealing with, sometimes the clearance, or if there is too much discrepancy between the anterior and posterior segment of the teeth, the path of draw could be an issue for the Essex appliance to fit properly. So you had to block out the undercut properly when you're generating this, and you had to obviously survey the cast to make sure that you have a path of draw that is easy for the patient to put it in and out. And what I usually tell patients is that if we are going in that route, the Essex appliance would be kind of what I explained to them is a Christmas ornament. You look at it, you don't touch it. So you're trying to be careful if you're going to be chewing on it, because you can have the surface of the tooth, or not only that, debonded, but could break depending upon the patient, what they are doing with it.
Very good. So let's take a look and see what we did, and we'll analyze some of these as we go on. Now, what adds to the complexity of these cases? We work in the anterior zone, the aesthetic zone. We know that soft tissue remodeling, bone loss is going to be one of the biggest challenges in achieving aesthetic cases, whether trauma or elective surgical cases. So every part of what we need to do from management of bone and soft tissue is to minimize the remodeling, loss of tissue, loss of papilla, and maintaining gingival margin. And the first thing that I want to point out in this particular patient is that luckily we have a thick tissue biotype. And that's really important in terms of a prognostic factor for what to expect down the line. We have a thick tissue biotype, relatively thick tissue, gingival tissue from a width standpoint, and that's a good green flag on our side, knowing that we are going to be a little bit safer in achieving the results that we come. So here, basically, the tooth was really taken out with finger because really nothing was holding it in. Just irrigating the site, very gentle curettage to remove some of the block clot that had been formed, essentially to refresh the bleeding margins of the bone. And that's really all that was done there. No flap, no incisions. I ordinarily do digital workflow, computer-assisted implant placement in every case, 100%. Like I said, Friday afternoon, 5 o'clock in the afternoon, this patient shows up. So the options of doing computer-assisted planning and surgical guide, which are still my recommendations, could not really happen that day. This would have been a delayed placement of the implant if we had decided to do that. One of the things that we have learned over the years is that immediate implant placement with site grafting can help to preserve the tissue much better than grafting the site and coming back later on to do the implant. So in essence, a situation that we are trying to make good decisions and judgments for the patient and kind of go back to the basics. So here really simply was a free-handed placement and position of the implant, done very cautiously with multiple checks, x-rays, looking at the occlusion, because we still have to be precise, even though we're not using a traditional surgical guide or a computer-guided assistance. So noted here is that the implant is still placed palatally. We have to place that implant toward the palatal aspect, very critical. We want to make sure that we maintain a gap where the bone graft is going to be placed. Here's our bone graft. Here's some collagen tissue. And here is the tooth that was simply bonded in place and creating the pontic ovate shape out of the tooth. I simply did that by adding some bonding composite resin to the fractured tooth and tried to create a pontic design. And this was just bonded into adjacent tooth on one wing. And this is about how far the ovate part of the pontic is penetrating the tissue, trying to shoot for about 2 millimeters of penetration of the pontic into the soft tissue. And the implant itself is going to be about 3.5 millimeters apical to the gingival margin, so that we can allow for proper emergence phenomena down the line. Any comments about the provisional, about the position, or about the pontic design, Flavio?
No, I think that having the contour that you create on the cervical third that we cannot see in there, that most probably you have reduced even more the tooth anatomy, and then making sure that you create an area that it is smooth, that is going to be against the soft tissue area. And then, as I explained to you, the bonding against both areas of the adjacent teeth sometimes can induce a crack on one of the ends, which is expected, obviously, because teeth wants to have some degree of mobility. And so most of the time, there's going to be one end that will fracture on us when we use just this type of procedure, right, without reinforcement on the lingual. But you have done a wonderful job, I tell you.
So this photo is about 2 weeks after the surgery. As you can note that the tooth number 8 is already had the completed endodontic treatment. So let's just from the timeline standpoint. And what I liked here, again, I think one of the things that I think we need to stress even more is the communication and collaboration from a surgical tissue management between, you know, myself or whoever is doing the surgery and the restorative dentist, because I think this is when we start to develop our soft tissue envelope, support of the papilla, support of the buccal tissue, and this is going to set the foundation for what's going to come later. So I think this is a good time to really have that conversation. And one of the things that I appreciate about working with Flavio and those like you who really sweat the details is whether or not there is adequate emergence, convexity, or concavity of the restoration, even in transitional mode, to be able to design this tissue and support it during the maturation phase, during the healing phase. Because we're going to be sitting on this for the next 3 to 4 months as the implant integrates. So, so in this case, I see that there is good buccal corridor and support of that soft tissue. We want to keep it there. And that's kind of the critical part of this restoration at this point.
I would assume that you want to keep gingival inflammation to a minimum. What are the cleaning instructions for the patients when they have something like this? How do you want them to keep those papillas clean?
Flavio?
Yeah, so on the area that it is right, for instance, distal of number 9, you have adequate access. I use proxy brushes that are different dimensions, and you can create with just an instrument, enough clearance for either have a superfloss coming through or one of the proxy brushes. Once you have completed the bonding, you can use some of very small diamond that you can create the access, either a mosquito or one of the extra large fine diamonds, to make sure that you can maintain adequate access to it. At the very beginning, you're trying to avoid putting too much, pressure on the soft tissue. I normally give patients extra soft brushes, like a Nimbus type of brushes, for them to maintain a good oral hygiene without disturbing the surgery site, and rinses with an antimicrobial rinse.
Thank you.
Thank you. So here we are looking at the post-op CBCT. By the way, one of the things I wanted to point out was regarding the immediate provisionalization of an immediately placed implant. The implant was checked with an ISQ, and it did not meet the requirements, which is 60 on the ISQ test. Hence why the tooth was submerged for healing purpose. If we had a sufficient stability of the implant and ISQ, we could have certainly gone to an implant supported provisional. And according to the dual zone therapy, we've talked about this from the studies by Tarnow and also by Salama, about how the stability of the bone and soft tissue can be enhanced if we have an immediate provisional on the implant with a gap graft, all three at the same time: immediate implant, bone graft, and a provisional restoration seem to offer the best stability in the long term. But we couldn't do it in this case, and hence why we just submerged it. And we can kind of see, yes, we have an implant in good position. We have good bone width, at least at the early phase. And here we are about 5 months later with a provisional out. The bonding was just removed so we can remove the tooth. And now we're getting ready to expose the implant and get it ready for provisional. So we still have a thick tissue biotype. It seems like we have a relatively good projection or buccal corridor on the soft tissue. So the implant is exposed in a conservative fashion. Again, no flaps. This is just a technique of removing the superficial part of the tissue. Incidentally enough, if I go back to this here, the tissue was quite thin. The ovate part of the pontic of the tooth was, I think, even about 1 millimeter from the implant platform. So we see that red tissue, which was very loose granular tissue. It wasn't actually a gingival tissue in the sense that you had to flap it. So really all I had to do was curettage that center part, and then I could see the top of the implant. So the exposure was really quite, with no flap. So one of the things we always talk about is, even though we have good bone, even though we have good soft tissue thickness, that we're always thinking about connective tissue graft. More and more over the years, we've gone toward more soft tissue graft, more connective tissue graft, especially in the aesthetic zone, than we used to. And I think we see the outcome of that repeatedly, which supports not only what we see, but also what is in the literature. Obviously, in this case, we don't want to do any invasive surgery to undo what we have already. So using the tunnel technique with a microblade to create a supraperiosteal pocket. Here's a connective tissue graft from the tuberosity, very dense tissue, about 1.5 millimeters in thickness. And this is simply just tunneled in with a single suture. And we can see the immediate overbulking of the tissue. And here's the patient in a couple of weeks. And the X-ray, healing abutment. And now the prototype restoration. I stress that we call this more of a prototype, not a provisional or a temporary, but more of a prototype restoration. Because we really need to kind of create the restoration to close as what the final outcome is going to be. And I think the prototype just is more descriptive to me. So Flavio, we look at this, where we are right now after, this is about 3 weeks after the exposure and after the provisional restoration. This is, the tooth was provisionalized within days after the exposure. We can still appreciate the sutures in place, the overbulking of the tissue. And here we are with the restoration. This is about 3 weeks after the insertion. The things that I'm looking at right now that kind of makes me concerned, perhaps, is number one, the black triangle. Number two, there is a little bit of a divot, perhaps a little bit of a scarring on the right side. It's early on. We'll give it some time to mature. But what are you thinking at this point when it comes to your provisional restoration, your prototype? How are you looking at this case?
Obviously, that looking at the anatomy of the tooth itself is one part of the equation. You can see that these teeth are more triangular in shape. And then knowing where the crystal bone is on the space between number 8 and 9 will be crucial to know, to have some sort of prediction if there is any chance for the papilla to go and close that space, knowing that there is a certain distance that we know when it is around 4 millimeters from the bone, there is a chance that we can have papilla formation to fill the whole thing. And sometimes you have to combine between a recontouring or addition of resin into the initial aspect of number 8, so you can have a contact point that is more ideal from the aesthetic point of view. The other thing is that I think that we discussed this from the point of view of the contour coming in the subgingival region of the provisional. We know that we want to create a concavity in the anatomy of the provisional to allow the tissue to get more thickness on it. Instead, if we are creating too much bulk, we can induce a tissue displacement more apically. So that's an important part of this.
Right, right. So obviously the contours of the provisional, I think, is really the game changer at this stage. Everything is really based on how this is designed and how it can be manipulated during the maturation phase, whether by convexity, more contour, under contour at the gingival interface, certainly the contact area. And these are areas that I think requires repeated checks. How often do you see a patient like this to see if you have to make any adjustments and modifications?
Yeah, if this patient comes after your surgery and I provisionalize, I will be having the patient in a month just to see how the tissue is maturing. And before committing to final restoration, I will give at least 12 weeks to have an assessment if there is a need for any modification of the adjacent teeth as well. But I will be giving at least some degree of maturation of the tissue to minimize changes down the line. There is still some changes that will occur. This patient is a young patient, so when we are discussing about this type of treatment, we had to make sure that the patient is aware that over time there is changes that may going to happen on the natural dentition that can affect whatever we are doing on the implant restoration right now. So the surgical aspect is so important right now, but then long term, the restorative plan has to be considered with revision procedures down the line as the patient is, getting older.
Would you say 3 months is the minimum you would like to wait for your provisional before you go to the final?
Minimum, yeah.
Minimum.
In the anterior segment, between 3 to 6 months. And obviously the type of patient gingival characteristic will play a role. If one patient that is thin and scalpel may going to be even waiting more than if I'm dealing with a patient that is a little more thick and fibrous.
Okay. Is there any cases or any situations where you don't use a provisional or a prototype in the aesthetic zone and go to the final restoration?
Yeah, if I have a patient with low smile line, very low aesthetic expectation, a patient in their 70s and 60s, and I know that the implant is very solid in place, and if you have already created a custom abutment, healing abutment that has the anatomy, I think that I will feel comfortable moving to final restoration. The advantage of provisionalization is that you can assess patient aesthetics, function, acceptance as the overall condition of the prosthesis before moving to the final restoration. Basically, the provisional become just a prototype of the only difference with the final restoration with the material. So that's the advantage of having the provisionalization on this type of patients.
Yeah. So here we are, 3 months later, a patient comes up into final restorations now. After 3 months of provisionalization, which is about how much this patient waited, this was the final case. Now, the teeth number 8 and 10 also were restored with full coverage restorations. That gives a tremendous amount of control for you, Flavio, to really design the entire area. I mean, look at the contact area. It's not even a contact point as we had it in the provisional. How crucial is, your vision when it comes to creating a harmony in the aesthetic zone, and what is it that you communicate with your laboratory, with your technician, about exactly where you want things and how you want things? Tell me a little bit more about that.
Yeah, so from the previous photo that I was talking about, the provisional, and you can see that the shape of this particular restoration has changed the original shape of the tooth structure. So by creating full contour restoration, you have a little more control of the line angles and having the chance to reduce more the ginger embrasure to the point that you can control the black triangle that you may be having in there. The other thing is, I think that from the aesthetic point of view, the technician has done a very nice job. One thing that I see, and always we have to look for symmetry. So if you see number 7, and I'm trying to be obviously very meticulous in this, and I tell you that the doctor has done a wonderful job with this. Mm-hmm. But if you see, always you're trying to look for symmetries between number 7 and number 10. If you look at the incisal edge, has a slightly different characteristics. Number 10 incisal edge has been created to mimic number 8, 9, and 11. But number 7 doesn't have the same amount of characterization, like the white, hypocalcification doesn't have it. So, and the other thing is number 10 has a bit more over contour, perhaps related with the amount of room that has been created by the preparation. Because if you look at the line angles of number 7, mesial and distal line angles are a little more slanted, much more narrower than number 10. But obviously, the overall condition when you started and where you are right now and what you have accomplished is an outstanding result. And I think that I mentioned about this, that the type of material plays a role. And based on the x-rays, I think that the colleague has selected to use zirconia, bilayer zirconia that you can see on the implant restoration, that you can see that radiopaque component that is the centerpiece of the abutment and crown, most probably is a screw retain. And then you have a little more radiolucent layer on the outer portion of the crown on both number 8 and number 9 that is showing the amount of ceramic veneering that has been added to the zirconia coping.
Yeah.
I had a question.
So here we are. Yeah, this is...
A quick question.
Please.
Flavio, we're looking at these two crowns of number 8 and number 9. Number 9 being the implant looks more natural than number 8. Is this just a material thing? Because I see the cervical area of number 8 looking very white and opaque relative to 9, or it may just be my monitor. Is there any reason that would be?
The room that you have. the restorative material has to have certain thickness, especially when you use zirconia, because you have to have, the zirconia is very opacious, even though we have improved significantly the different type of zirconia that we are working with. And the amount of room that you create in the preparation, enough thickness, so you can create a layer of the ceramic that can be masking the substrate. In this case, you can see in the cervical margin of the crown. And one of the things that I tell you that happens to us over time, there is going to be some modification that will happen at the gingival level that is going to be more notorious on the natural teeth than on the implant. Because the implant, obviously the head of the implant is farther up, and you have all ceramic emerging at that level. So if there is any modification of the soft tissue around the implant, they're not going to be so crucial as it is more on the natural tooth.
So would you have prepared the preparation more aggressively on the labial, accounting for this?
I would, at the stage of the provisionalization, I will measure the thickness. Obviously, zirconia you can have from this point of view of the strength, you know, within 0.8 millimeters, you can still get a margin of 0.5, but you need to have enough room, because you have to have enough cover of the substrate, which is the dentin in this case, and part of the cementum, and you have to be a little more aggressive in the reduction and where you are locating the margin of the preparation. In this case, on the anterior segment, I usually pack a cord. I deliver a 000 cord, and then I bring the margin slightly subgingivally. Overall, I think that the result, you know, was very good.
Great, thank you.
Great. And certainly, you know, from standpoint of her smile line, which, you know, it's average, does show the papilla, the gingival margin, if she really overstrains or overanimates, was visible, but certainly, I think overall, the natural result, there's some sort of natural asymmetry, maybe to some degree, that kind of creates a little bit of a more natural smile, perhaps. But certainly, from an aesthetic standpoint, was good. But one thing I want to kind of point at is, you know, are we going to see what we see? I mean, this is very early on in the treatment, and I always wonder what's going to happen down the line. What is the soft tissue stability? What is the stability of the aesthetics and everything that we've done so far? So yes, good symmetry, good placement, good outcome. Certainly, we have preserved the overall architecture fairly well during the early phase. So 2-year follow-up. She comes back, and this is her photos 2 years later, quite stable. The soft tissue and papilla, gingival margin, certainly more mature and better, seem to be holding quite well. I agree, Reza, you have a good pair of eyes. Now that I see more the appearance of the crown on number 8 and number 9, I think the implant looks even more natural than number 8, but there's certainly, there's a little bit of a grayish hue that I see between the two. Anyway, one of the things that, and certainly the bone is stable, the implant is healthy, really from a stability standpoint, looks really great. But it's interesting, I took a CBCT out of curiosity, because we think that stability of our tissues, whether bone or soft tissue, and as thick as the bone was, whether or not that stays or not. And I think that's one of the questions we have to look at harder. So here's tooth number 8. This is 2 years later, as seemed to be fine. And here's tooth number 9. And one thing that I can kind of look at is that the bone stability may not be as good as what we had hoped. Remember, we did a gap graft. We had a thick amount of bone. Look at 2018. We had literally almost about 2 millimeters of bone thickness. And if I look at 2020, that bone is probably down to 1 millimeter. There's certainly remodeling and shrinkage. And want to point out, there was no flap. There was no periosteal elevation. The only thing that was done was a supraperiosteal tunnel for the connective tissue graft. But nevertheless, we have bone remodeling and bone resorption. This is not clinically significant. Certainly the implant is integrated and well supported, but there is bone changes clearly between 2018 and 2020. Which takes me back to one of the points I brought out earlier, and I think the emphasis on the importance of soft tissue. And I think I've heard this from many speakers on the podium, is that if you had to take your choice between having an abundant amount of a bone and an abundant amount of soft tissue, I would take the soft tissue. We have seen that not only protects the underlying bone to some degree, but also the outcome. And I think the only thing that's really has perhaps saved this case from a visible, clinically different outcome 2 years later, even though we have bone loss, was really having a thick gingiva from the connective tissue graft. So as I look at this case, I'm so happy that we did the connective tissue graft. Did it really need it? I'm not really sure. We look at a case like this with a thick tissue biotype, and it's very easy to say we're done. Why should we expose the patient to additional connective tissue graft, additional surgery, and additional cost of the treatment? But I think I look at a case like this, and I wonder if the bone changes that's clearly different from 2 years ago would have manifested itself if we hadn't done the connective tissue graft. What are your thoughts, Flavio?
Most probably you will have a very thin grayish color on the cervical third of this restoration closer to the implant. I think that creating the foundation from the point of view of having a very good solid bone foundation, and in addition, enough bulk of soft tissue is crucial for anterior segment restoration for implants.
Yeah. So, so I think, you know, the takeaway point for me is confirming or reaffirming or reassuring me that we need to really think about the connective tissue graft and our soft tissue architecture, even in situations with abundant bone. I've become more and more advocate of grafting these anterior cases to minimize remodeling down the line. The last thing I want to kind of bring up is...
sorry that I want to add something very crucial. You were very meticulous on the position of the implant. Imagine if this implant would have been with just a slight labial angulation, and you already have a very good implant with adequate amount of bone grafting, and you had seen some recontouring of the bone architecture. Imagine what would have been if you have had an implant with the wrong angulation.
Yeah, well, disaster.
Yeah, that's a very important point.
We see those cases quite often. That's where it becomes disaster, and one of the, I think probably one of the most common complications in implant therapy in the aesthetic zone is the recession, loss of tissue, gingival asymmetry, just from exactly what you were describing. So I think that's a very crucial point. So one last question I wanted to kind of bring before we close is Pirooz and Reza, in terms of endodontic follow-up, tooth number 10 was fractured. I'm going to call it some level of contusion. I'm sure the tooth that's fractured under trauma has some level of contusion, maybe not early sign of necrotic pulp or changes in the endodontic dynamics. But what is your outlook for the future? How are you concerned about that tooth, about becoming non-vital, and how often do you want to see this patient for a follow-up?
Great question. Rez, you want to take it, or?
Oh, you go ahead. Yeah.
I think it's important to keep an eye on it more frequently early on. So I would definitely do a pulp test initially, and then I would follow up with another pulp test in a month, and then on a quarterly basis for maybe 12 months. And then after that, to pulp test it maybe every 6 months the next year, and then on, after that, if it's fine, the patient's going to have 6 monthly checkups anyway with images. I think early on is more important than keeping pulp testing it, into eternity.
Yep, definitely.
And at what point would you feel comfortable that the tooth is not going to change? Would it be 12 months, 2 years? Is there any data on, when you might feel comfortable about the stability of the tooth from an endodontic standpoint?
I don't think there's a point where I think the longer you go, then the less likely it is that the tooth is going to have an event. But I don't think there's a line in the sand where you can say, hey, if you haven't had issues in the first 24 months, I can guarantee that you won't have issues going forward. But if I were to draw that curve, the probability of it having issues later on is less.
Yeah, and the important thing is also the type of injury. So tooth 10 had basically a fracture in enamel and dentin. So really, other than the bluntness of the force of the trauma, which you want to just monitor over the short time period, these types of injuries are really like you've won the lottery. It's very different than if a tooth was luxated or if a tooth was avulsed. Those are the ones that you really want to really scrutinize and follow up long term for pulp vitality.
Yeah. Very good. Thank you for that. Before we close, any last minute thoughts?
No, just one of gratitude. I think this is a great idea. I think this turned out to be a great case, and just grateful to have been included.
Thank you. I appreciate it. Thank you, Reza, Pirooz, and Flavio for taking part. I know that we learn so much when we actually do real conversations about these cases, and I think what we did, discussing this case is no different than what it should be in real life. When a patient of any type of need that requires this multidisciplinary team approach, I think we gotta, that's what we do. We talk, we look at each other, and we put each other in a position of saying, tell me, what do I need to know? How do I sequence this? What is the order? And how to kind of align this so that from a patient standpoint, they see a very concerted, sequenced event as efficiently as possible with no miscommunication and issues. So I think the conversations that I've had multiple times regarding many different complex cases has allowed at least me to kind of stay on top of what I can do and make sure that we're working in alignments together. So, so really, thank you. I appreciate your time. I hope that everyone who joined us today liked what we did. We're going to do more of it. We have planned a monthly case discussion with different cases and different clinicians. And thank you for being here. We look forward to having you guys again soon. Thank you again for being. Appreciate it. Love you guys.
Thank you guys.
Talk to you soon.
Thank you.